Oops. Hi, my name is Cindy Carlson. I'm a geriatrician physician scientist here at University of Wisconsin. And I'm thrilled to be here today. Geriatricians love interdisciplinary teams, and so I would like to stay tomorrow for all the science aspect, but my son is graduating, so I don't know. Yeah. So my background, so again, I'm trained as a clinician in geriatrics, so I have that clinical perspective. But then when I was a resident and fellow, I started doing training in population health sciences. So I started doing, first I'm a clinician, then I started doing clinical research, started learning about that, then started doing population health sciences, learning more about surveys. And then now as director of the Alzheimer's Institute, we do more work. We're trying to link some of the biomedical data to electronic health record and other data. And so thinking about how we define dementia from different perspectives is really challenging. And then I was involved with the redesign of the National Alzheimer's Coordinating Center data these last 5 years. And so we'll talk some about that and that being a resource for social scientists as well. But I think what it showed me is that there's so many different ways we define dementia. And so we'll just kind of walk through some of that and talk about some of the resources available. So I'm going to start with this. So this is what we usually start with. It's a single person. This is my grandmother who was diagnosed with dementia in her early 70s. So again, we start whatever kind of research study, clinic we're in, we're starting with a person coming in with some memory complaints or cognitive complaints of some sort, or someone else is noticing some complaints. So if we define dementia, and again, I'm going to try to build on what Dr. Carver said and what Dr. Sana said. So we define dementia, we have to think about what are we going to capture from this individual coming in with these memory complaints. So sometimes we'll be able to do some cognitive tests and document some of those cognitive changes. When the person passes away, we'll be able to look at some of the autopsy data, which again anchors us to the pathology. But again, this is going to be a snapshot in time. So this person, let's say she's having some memory complaints, she's having maybe some language problems, she's having some problems with complex decision making. So we're seeing her that snapshot in time. This is what her cognitive score is that day. Then an autopsy, that's what her brain looks like afterward. So again, but what we can do is enrich the data. And so like Dr. Carter was saying, if we get longitudinal data, then we can step back and say, oh, 10 years ago, she was not like this. 10 years ago, she was very articulate, was a French teacher, was able to, very witty. So again, we may have some cognitive data previously, but what we're really trying to do is can we go back and see what are the very earliest brain changes that happen in this individual. So again, the richness of being able to not just look at that snapshot, but can we go back and find her before she gets the cognitive symptoms? Can we link that to some of the early pathologies? That's where a lot of the biomarkers come in. And so as Dr. Asana showed, again, when we look at this trajectory, so again, somebody's cognitive decline, if they're on a path toward developing dementia due to Alzheimer's disease, they're going to have this accumulating Alzheimer's brain changes over time. These are the biomarkers that we're trying to identify, because again, we don't want to wait till somebody has symptoms, because by the time I see them in clinic as a clinician, so again, by the time they have dementia, their families brought them in, they've already had 20 years of pathology sitting in their brain. So again, that's what the work is working for, trying to identify what are these, before we develop new preventive therapies, we really have to be able to look and see what are the earliest biomarkers here. So again, a lot of their work now is trying to define biologically what's happening before someone has cognitive symptoms and then following them longitudinally. And so again, we've heard from Dr. Sana that again, the key pathology that's been identified for 100 years now by Dr. Alzheimer's is this amyloid plaques and the neurofibrillary tangles in tau. But again, those two biomarkers, while we can find those very well now, and we have a lot of other biomarkers to do, and you'll hear about, we need to find a lot more biomarkers, and you'll hear more about that today as well. That's not the color I picked. Anyway, you've seen these diagnostic criteria, but the reason I want to point out these again is because, again, the definition of dementia, and so this is, again, dementia and Alzheimer's disease, people get those mixed up, so I don't want to talk down anyone, but it's very common that even still in research. So dementia, again, it's a clinical syndrome, what we're going to see in the person. My grandmother coming in and having those symptoms. And again, those symptoms have to interfere with their daily activities. So we have to get a sense of what kind of changes has that person had. Well, if she's a French teacher, can she teach French anymore? Can she not do that? she's a quilter, can she do the quilting anymore? So it interferes with their functional activities, and it's a decline from their previous level of functions. That longitudinal data is critical. And even like with HRS, I was pulling up they have like how was your memory 2 years ago? So being able to see what will change, like not explained by delirium or major psychiatric disorders. Were they in a hospital setting, or were they sick from something else? They're not supposed to have that either. And then it has to be taken from patient and a knowledgeable informant. So this is where a lot of our survey data, a lot of our population-based data, we're usually asking the person. Sometimes there's other informant data, but in our Alzheimer's Centers program, there's a mandate. We have to have an informant, because if we have cognitive changes in our frontal lobes, we may not be able to identify that we're having changes. It may not be a denial issue, it's just we can't identify that. And then a cognitive change. And then it has to be several cognitive domains. And you'll hear today, I think Dr. Williams and others are going to be going through, like, what are some of the cognitive domains? And so that's why I look at HRS and some of the population-based studies. There are these different kinds of cognitive tests to test memory, language, quickness of thinking or processing speed, etc. So again, key things with IDRC data is that we have the knowledgeable informant, the cognitive domains, and then a careful history of that change in that specific individual. And that's time consuming. So that's the hard part, is that it's hard to capture with quick questions. So when we think about that's dementia, what we see in the person, then we're looking at the etiology. So the etiology is, again, what we were talking about, use of biomarkers. And so back in 2024, the Alzheimer's Association put out data for Alzheimer's disease. And this caused an uproar among clinicians because it defined it biologically. So what they said then is not only do they have to have this clinical progression, but again, the stage 0 is if they have no biomarkers, evidence, no cognitive change. Stage 1 is when they're starting to have biomarker changes, but no cognitive impairment. Stage 2, again, getting some cognitive impairment, and then progressive functional change over time. So again, there's this key integration of, and we'll hear about the types of biomarkers that are integrated into those diagnostic criteria. So again, there's some limitations in what we can do with population-based data, but again, the flip side is it's costly and time-consuming. So partnering, trying to understand what are the best measures is really important. And as Dr. Aslama said, we know that most dementias are mixed pathology. So again, we're trying to look and see. Right now, we can identify if they have Alzheimer's, yes or no, but we can't say for sure, do they have Lewy body, yes or no? Do they have vascular contributions? We can get some idea, but not. We still have a lot of work to do on those biomarkers, which Dr. Johnson and Dr. Wilson will talk about. And then for each of these other causes, there are diagnostic criteria for that. So we've gone through the diagnostic criteria for dementia, Alzheimer's disease. So again, there's specific clinical criteria that kind of match up with the pathology. So again, there's a lot of details to really kind of carefully describe an individual. So when we think about data from, let's say, our claims data or a death index, or the other looking at electronic health records. We've been working at Alzheimer's Institute again to link the Alzheimer's Center data, so with some electronic health records. It's only as good as our clinical assessments, right? So, as a clinician, if I have training, so I have a memory clinic at the VA, we're heading to after this, but I have a memory clinic. I've done memory care for a long time. But if I'm a geriatrician and maybe I haven't had, I'm in a rural area and haven't had an opportunity to get the extra training, maybe I'll just, somebody comes in, they're confused. I might get a little bit of a history. Maybe I missed that they didn't tell me they're on some extra doses of Benadryl or other things that I've missed. And so I think they're coming from Alzheimer's, because I have read that that's the most common cause. But maybe they're on some other medications they didn't tell me about. So those, again, our clinical assessment is only as good as our access to good education about dementia, resources, how much time someone has. So, commonly I'll get consults from people who, the primary care providers, done like 10 things. And then at the end, the patient says, and I'm having confusion. And they're like, memory consult. So because there's so many factors that older adults are working through. So again, our clinical diagnosis was going into our electronic health record, our claims data, and even our death index. So I always think back to my medical school training. I had one lecture on how do you fill out a death certificate. And it was, it wasn't very long. And I still remember the guy speaking up there, but I don't remember all the details about, so you're supposed to put down like somebody So if my grandma, let's say, had pneumonia from aspiration due to Alzheimer's disease, it's supposed to be that kind of progression. But if I'm just meeting a patient and they come in, they've just died, and they're in the hospital for pneumonia, I'm going to put down pneumonia as the cause of death. So we all know that all of our data sources are imperfect. We want to work toward them being less than perfect. But the more I realize the ways you can describe things, there's caveats to everything, including our ADRC detailed diagnostic approach. So again, and I just wanted to point out in a clinical setting, so if we're using data from a clinic setting, the data that can go into supporting that diagnosis usually is CT imaging, MRI imaging. So in most clinical practices, they're not going to be using PET imaging yet or biomarkers yet. So a lot of the data we have from other EHR, et cetera, they may have looked for atrophy or shrinkage of the brain, significant vascular changes, tumors, things like that. But they're not going to be able to verify if there was amyloid in the brain or tau in the brain from what the data they have. But we do have newer tools that Dr. Johnson and Wilson will speak about, and Dr. Bedhauser too, reflected. We'll be talking about some of the new neuroimaging tools, the PET scans. So again, PET scans, it'll depend on what tracer you're going. So that's been the real breakthrough, this human vector tracer that sticks well and reflects well what's going on with the amyloid in the brain, a separate tracer that would you'd inject and look and see what the tau levels are. And then down the road, we'd hope to have tracers that would detect TDP-43 and other proteins. So again, these are things that are going to be moving into clinical practice. So right now, our clinical EHR, et cetera, is not going to reflect these very much. And then we've heard that, again, it's not just Alzheimer's, a lot of other. And so we've seen a slide about other potential causes, but these are data from very well characterized Alzheimer's participants with excellent clinician overview. They were thought to have Alzheimer's dementia, and then on autopsy they had either Alzheimer's, other causes of dementia, plus vascular about half. Alzheimer's had vascular about a quarter. So really, just having Alzheimer's disease is really a small sliver. And so again, these are very well characterized participants. It's not, so again, we're not even the best detailed clinical assessments still have the caveat that there's lots of pathology and we have a lot of work to do to understand how that affects the person. So again, if I have changes in my brain that's more frontal lobe, no matter what the cause is going to be more disinhibition, inappropriateness, that, if you have somebody who's got more temporal lobe changes, they might have more language changes. So like for my grandmother, they diagnosed with Alzheimer's disease, but she had some language changes and had ALS as well. And now looking back, we can say, oh, it's probably, TDP-43. So we can make some diagnoses later on. But again, right now we have limited resources. So just thinking about different ways we can define dementia. So we've talked about the National Death Index, death certificates. So again, it's only as good as the clinician filling out the death certificate, unfortunately. So pushing for good education in those contexts. Again, claims data and ICD-10 codes. Again, when I'm in clinic, do I pick, I think it's probably Alzheimer's, but I'm not 100% sure. So am I going to pick the cognitive disorder or cognitive changes with increased awareness, or what other ICD-10 codes am I going to pick for that diagnosis? And electronic health record data, I think it'll gradually improve, but again, it's limited based on what our clinicians, how well they're trained. So, and trying to understand how that fits with other data is, I think that's something where AI and these linkage studies that we were talking about can really be beneficial. Epidemiological data, again, that, as you all are very familiar with, you can have different kinds of, you can have a trigger question that does a staged kind of assessment, or just, questions that get at the change over time. But again, it's hard to capture the informant information, et cetera. So that's where we get to these standardized clinical cognitive and biomarker assessments that are done as part of the ADRC program. But again, with this, each of these assessments, Dr. Aslan was saying, the ADRC and the RAP, each of these take about 5 hours per person. So multiply that times HRS worldwide, and probably not going to happen. So, right. So the UDS-4 is where we are now. So a unified data set was started in 2005, and before there was a minimum data set. But again, this was launched then, revised a little bit in 2008. 2015 had a major shift, and it's a version 3. And then just this past 5 years, launched last year, we revised it to version 4. And so I'll talk a little bit about some of the key changes that have happened in the data. But again, it's really viewed as the gold standard neurocognitive clinical and phenotypic data, and it's used by a lot of studies worldwide. And so these forms, and there's a handout in your folder, Felicia, that has QR codes to look where to get these data, because these forms are all publicly available. So you can look at them, see what kind of questions, how they ask them. And as part of this committee, we tried to align different types of questions based on advances in other literature, sort of like traumatic brain injury and obstructive sleep apnea, and try to make sure that we're aligning with other groups as well. So they're pretty robust data. They're available in English and Spanish, and they're working on finalizing the Mandarin and Cantonese forms as well. So these are what the UDS covers, so the uniform data set. So a lot of these are things that you would collect as part of a lot of different social science or public health evaluations. So participant demographics, social determinants of health. You'll hear from Dr. Zielsdorf, again, trying to better understand how do different factors we don't typically capture well in our data, like discrimination and other factors at lack of resources, which I think a lot of our social scientists would do a lot better job accessing. We try to increase that within our UDS data set. Co-participant demographics. So trying to capture a little bit how well does this person know the person who's here? So sometimes in our Alzheimer's Center, we'll have somebody who's been a friend with someone and they don't want to tattle on them that they're having memory problems. So they might say, oh, no, their memory's fine, when they were really in trouble. Or you get the son who is now the new study partner and they haven't seen them for 3 years and they say their memory's fine when really they're not doing fine. So again, the study partner is really important. So then some of these information is pretty standard. The ADRD specific treatment. So now we have 2 therapies that remove amyloid from the brain. And so now our data sets are trying to have to change these data so that we can, or to capture what's happening out in the clinical world. So which can be these new anti-amyloid therapies. So you'll hear more in the full clinical physical examination. There's a standardized approach to blood pressure measurement because of the emphasis on vascular disease. And then you'll hear today about some of these cognitive assessments. And then really the key thing I think that is critical for the NAC data set is these, like the clinical judgment of symptoms and pulling together the forms we call D1A, D1B. What's the clinical syndrome? How does it fit with the etiology? So this is why we try to piece together all these information. And I see Marissa in the background who coordinates our consensus conferences. You'll see a mock consensus conference. She knows all the details we go into these consensus conferences to get to the right diagnoses. So
and all the data that Dr. Carlson has talked about, UDS, is collected throughout all 35 ADRs.
Yes.
It's all harmonized across the ADRC network nationally.
Yep, and I'll show you how to access that data. So this is just an example, again, trying to clarify what type of diabetes someone has, what their treatment with, and then trying to get a kind of a dose duration effect. How long do they have hypertension, for example? Another one, assessing repetitive head trauma. So there's been more in the data recently about all my sons who played soccer did headers and the people who played football and those repetitive head traumas. So trying to align with the TBI research being done, making sure that we're asking questions in the right way. And then again, like I mentioned, I think the key part is synthesizing the clinical syndrome and the etiology. So in this case, again, after a review of the data, the course, we have these MCI core clinical data. Did they have a concern? Did they have one or more cognitive domains, function preserved, and which areas were impaired? And then trying to get at the etiology. So in these meetings, we have consensus conferences, we go through, did their biomarkers look consistent with Alzheimer's? And again, because the biomarker field changes so fast, and again, this is a change that happens once every 10 years, we leave it up to the centers to say, what is abnormal? Because it's changing faster than we can change its forms. And then trying to pull it together. So did those biomarkers, the imaging, look consistent with Alzheimer's disease? Maybe it was a couple, maybe we think it was a couple things. So it gives you the opportunity to say, you know, we think Alzheimer's was the primary, but also some signs of Lewy body. So these data, as Dr. Asana mentioned, these are my last slides. You can request the data. So again, there's a very rigorous way to submit this, and also query system to make sure that the data aligns. But again, you can request data. There's numerous, and again, it links to neuroimaging data, and you can request from the centers. There's also a linkage to a center that has access to blood and spinal fluid tests called the NECRED. So again, this page has and if you go again to the page I listed, you can look around. But this one, again, is the data request process. It shows you what data is available, how to approach requesting these data. So I'll stop there, but again, hopefully give you just a sense, and I think it'll tie in with a lot of the things you'll be seeing today, the imaging data, the fluid biomarkers, the cognitive data, and then how it's synthesized kind of in a mock consensus panel. But again, it's imperfect, but again, I think we all learn from each other and how we can best describe Alzheimer's disease.